Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we are discussing transcatheter aortic valve implantation, also known as TAVI. TAVI has become pivotal in the cardiology space since its introduction in 2002, and today we'll compare transcatheter aortic valve implantation, TAVI, to surgical aortic valve replacement, SAVA, and its place in low surgical risk patients. We'll also discuss the importance of shared decision-making for patients with aortic stenosis. This podcast is sponsored by Medtronic. The views expressed in this podcast are not necessarily those of Medtronic. To learn more, we are joined by consultant cardiologist Dr. Jason Sharp and Dr. Dennis Wang from the Sydney Adventist Hospital in Sydney to discuss some key updates in the TAVI space. Dr. Sharp, I'll start with you. Can you give us a brief overview of where transcatheter aortic valve implantation TAVI procedures are at right now and how that has evolved over the years?
Yeah, Sally, I think it's been a very interesting journey over what seems like a short period of time, but it's actually longer than perhaps you might imagine. The first TAVI case was done 22 years ago. And a lot of us, I guess, are still thinking of it as a new technology, but it's really not so new anymore, to the point where, in 2019, there was a meta-analysis done of 7 very large studies, which led to a total of 8,000 patients comparing TAVI to surgical aortic valve replacement in patients across the entire spectrum of surgical risk. And that study, published in European Heart Journal, showed that the mortality rate for TAVI was actually lower than for surgical aortic valve replacement. And so this kind of data that we've got now is really strongly supportive of TAVI across the board for aortic stenosis, and that's a pretty major shift. As you would be aware, historically surgery has been the main option for treating severe aortic stenosis. Medical therapy doesn't really work, but now that we've got transcatheter aortic valve replacement, it's really been a big game changer in this space. And the shorter length of stay in hospital, the quicker recovery, and the long-term results now being so good, it really puts us in a new place that's, I guess, taking a little bit of adjustment, but certainly the results so far have been very good to see.
And guidelines have recommended TAVI as a suitable treatment option over SAVA across a range of patient groups. Can you talk to that, Dr. Wang?
Yeah, thanks, Ali. And following on from Jason's answer, I think the expansion of TAVI has meant that the guidelines have changed. We look at the ESC, or European Society of Cardiology guidelines, and the American Heart Association, or the ACC guidelines. They're slightly different, but the basis is the same, is that if you're elderly, and I think if you look at the ACC guidelines, if you're above the age of 80, or in the European guidelines, you're above the age of 75, the recommendation is for you to have a TAVI. And I think the ongoing guidelines also look at younger patients, and I think that's to do with low-risk patients, and the results being so good is that when you have a younger population, it's no longer restricted to just the high-risk inoperable group. So there is a grey zone, which is the patients sort of in that sort of 65 to 80 age group that you could be considered for both surgical valve replacement or SAVA versus TAVI. This is determined by a heart team meeting as to what is the best option for patients and whether we can obtain an excellent result with TAVI. And for those who are younger, and I guess we're looking at those less than 65 years of age, they really should be considered still for surgery unless there's something prohibitive for surgery. So you can have a young patient still considered high risk with perhaps shortened life expectancy or other comorbidities that should be considered for a TAVI. But in general, sort of TAVI is now recommended across a reasonably large age spectrum, except for those who are considered to be quite young, in which case we should really still think about surgery for these patients.
Dr. Wang, how are you seeing your clinical practice change in the TAVI space and perhaps the range of patients you're seeing?
Yes, that's correct. When TAVI was officially approved here, it was only for high-risk inoperable patients, and now we have an expanded indication for intermediate and low-risk patients. So that takes into account, I guess, generally younger patients who are low surgical risk. So across the risk spectrum, TAVI is now approved for reimbursement.
And Dr. Sharp, I understand that there has been momentum to investigate the safety and efficacy of TAVI compared to surgical aortic valve replacement, specifically in low-risk populations. There's also been the important Evolute low-risk study. Can you tell me about this study and which patient populations were involved?
Yeah, Sally. I mean, I think this is really the big change in TAVI recently is that this low surgical risk population has been looked at. Previously, these patients would have undergone open surgery, but now there's quite a bit of data coming through about how these patients do with TAVI, and the results are pretty impressive. The trial you're referring to is the Evolute low risk trial, which has published its 4-year data, and this year it'll publish its 5-year follow-up data. The patients were 74, the mean age of the patients in both groups. It was basically a randomized trial comparing surgical to a transcatheter aortic valve replacement, about 1,400 patients. And it was set up as a non-inferiority trial, but in fact, it's showing that the TAVI group is doing better. So they had a primary endpoint of all-cause mortality or disabling stroke, and at the 4-year mark, 14% of people in the surgical group had this endpoint, and only 10.7 in the TAVI group. So in fact, what we're seeing is that the TAVI patients are doing better, even in these low surgical risk cohorts.
And Dr. Sharp, this was a 4-year study. What did the latest results show, and what should we take away from this?
Yeah, Sally, I think the one of the interesting things about the Evolute data is that they consistently show lower mean aortic valve gradients and higher effective orifice areas compared to surgical aortic valve replacement, right from implant all the way through. And I guess the hypothesis is that this improvement in valve hemodynamics is perhaps what's driving the really good data that we're seeing on TAVI coming through, and perhaps the longevity of these valves. The Notion trial is one that I really found to be a particularly important study. Only 280 patients, but basically randomized 140 to TAVI with the Evolute valve, and the other 140 to a bioprosthetic valve. And if you look at what happened to these patients over a 10-year period, bioprosthetic valve failure was actually better in the TAVI group, 9.7% at 10 years versus 13.8% for the surgical group. And we weren't expecting this. When we started doing TAVI in elderly patients who were, not able to have anything, we were pretty happy if the valve lasted 4 or 5 years. But what we're in fact seeing is that these valves are really durable. And I was sort of highly reassured by this Notion trial, because I looked at it and thought, hang on a minute, these patients are doing really well. And we're not sort of compromising on long-term results compared to surgery. We're actually seeing better results. Really nice data coming through from both the Evolute low risk trial and the Notion trial. Notion looked at all-cause mortality, stroke, myocardial infarct at the 10-year mark and showed no difference between TAVI and surgery, and they were all low surgical risk patients.
As we've discussed so far, TAVI has come a long way from previously being reserved for high surgical risk patients to now having broadened indications across a range of patient groups, with supportive evidence for low surgical risk patients, as we heard from Dr. Sharp just before. And so, Dr. Dennis Wang, as the patient population eligible for TAVI expands, there's increasing focus on the importance of shared decision-making, or SDM. Recently, the Global Heart Hub released a patient guide on SDM for individuals with heart valve disease, highlighting both SAVR and TAVI and aiming to empower patients to have informed discussions with their healthcare providers about their treatment options. So as this field evolves and we see growing data supporting the safety and efficacy of TAVI compared to SAVR across various surgical risk groups, how do you envision the role of SDM in this context?
Look, I think the shared decision making will be one between an interventional and structural cardiologist and perhaps the referring cardiologist as to what type of therapy that we may want for this patient. And I think the other, shared decision making is also between us as a team and also the patient. As this space evolves, what we'll probably find is that there'll be more knowledge about the therapy. Patients may opt not to have surgery, even if they're young, and that's something that we need to, I guess, speak to the patient and the referring doctor about the pros and cons of each choice. So I think as this space evolves, there's no doubt that it will be a team decision between, I guess, the operators, the interventional cardiologist, the referring physician, if it's from a non-interventional cardiologist, and also taking into account the patient's choice as to which type of therapy they may want. So I think it's going to be an important part going forwards.
Dr. Wang, do you believe we will ever arrive to a point where patients will be advocating for their valve of choice?
Look, I think since TAVI has been evolving, especially with the approval of intermediate and low risk patients, we are definitely seeing a wider age group of patients presenting for TAVI. We're also getting patients who are coming to see us with the awareness of TAVI. And I guess it is coming down to patients who have perhaps come to us with knowledge and want a particular type of therapy. Now, whether that's appropriate or not is something we as physicians and as a team need to decide whether that's appropriate. But I think the vast majority of our patients who have severe aortic stenosis are coming in and looking at TAVI as an option. They're no longer sort of completely blinded by the choices they have. And I think we'll see more of that as sort of the TAVI space grows over time, I think.
And for Dr. Sharp, on a similar note to shared decision making, tell me about the mandated heart team and what that means for TAVI patients compared to surgical patients.
I think one of the big things that came with TAVI was actually the heart team. And prior to TAVI, most of us worked as really independent cardiologists, independent cardiac surgeons. There were some clinical meetings, but on a fairly ad hoc basis. But part of TAVI involved a mandated heart team meeting for all patients undergoing the procedure. And what that's evolved into is actually a really helpful meeting where patients are discussed between cardiologists, cardiothoracic surgeons, anaesthetists, geriatricians, all different people who have different ideas about how the patients should be managed, different aspects to their care that it can be discussed and considered. And also input from radiologists. I mean, we've picked up all sorts of funny things, not so funny, but, lung cancers, lots of other pathology that's been identified on some of these CT scans that were unexpected. So the patients get really thoroughly evaluated. They get carefully discussed. And also some of the difficult patients, because not all aortic stenosis is just slam dunk severe aortic stenosis. There are some of these patients with low flow, low gradient situations which can be difficult to assess. And, I think the heart team's been very good at deciding, okay, yes, this is actually severe aortic stenosis, so we should do something, and then deciding what that is. And also really helping to make sure that the patients are properly evaluated and that, and I guess, for the patient, their patients like to hear about the fact that they're discussed at a heart team meeting and that lots of specialists have thought about their case, and you can understand why. Really, they're getting a whole lot of opinions, and I'm sure that's likely to improve their outcomes.
Dr. Wang, would you like to add to Dr. Sharp's answer?
Yeah, Sally, I think the heart team meeting is probably amongst the most important changes that we've undergone with TAVI and other structural heart procedures. The heart team comprises a number of our colleagues from interventional structural cardiologists to anaesthetists, cardiothoracic surgeons, and we also have our TAVI coordinators and nursing staff, all part of the team. It is, I guess, designed as a safety mechanism so that all patients are carefully vetted for this procedure. It also allows us to discuss difficult cases where it's not so straightforward as to which therapy is best. And I think the heart team is going to be very important for a number of factors. For patients who are demanding a TAVI when we perhaps feel it's not appropriate. And I think to be able to have a heart team discussion and provide a consensus opinion to either a referring cardiologist or to a patient is quite important, so that this is not a one person decision. And it's often difficult when you are trying to deny someone a therapy that they want. We still have to act in the best interest of the patient, and perhaps even to a referring cardiologist who wants the patient to have a TAVI, we need to be able to show that there's a consensus for this patient to undergo a certain type of procedure, whether it's TAVI or not. And so having that kind of opinion is quite important, both I guess patient safety, patient reassurance. And for us as operators, the heart team is invaluable in just helping us make some of the difficult choices for these patients. So I think that's probably been the biggest change in sort of doing structural heart procedures, and especially TAVI, is to have this combined heart team meeting. I think it's going to be very important going forwards for, I guess, more potentially challenging and difficult decisions to come for younger patients in particular.
Thank you for providing us with this update on TAVI, Dr. Sharp and Dr. Wang. My guests, Dr. Jason Sharp and Dr. Dennis Wang, are consultant cardiologists from the Sydney Adventist Hospital in Sydney. This podcast has been sponsored by Medtronic. The views expressed in this podcast are not necessarily those of Medtronic. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for listening.